Hey, it's Elizabeth Johnson, President of NAMAPA, and I'm excited to bring to you a presentation on 340B. Thank you to Courtney Lang and Jeff Davis from 340B Health for this wonderful presentation.
We are delighted to offer this course, 101 on 340B, an overview of the 340B program. My name is Courtney Lang, founder and principal of Langco and Partners. My colleague, Jeff Davis, and I will provide an overview, background, history, and important details about the 340B advocacy for access to patient care. This is an on-demand listening session, and we are beginning right now. Jeff?
Thank you so much, Courtney, and happy to be here today. As Courtney mentioned, my name is Jeff Davis. I'm with the law firm Baker Donaldson. I'm of counsel in the firm's health law group and a senior advisor in the firm's government relations and public policy practice. I work with 340B Health, the association that represents hospitals in the 340B program, and really happy to be here to share a little bit of background about the 340B program and in particular how hospitals rely on this really incredibly important program that's part of the healthcare safety net to fund care for low-income patients. So I think to start off, we'll go through our learning objectives. We're going to provide a little bit of background on the program, and I'm going to talk about its history and what types of providers participate in 340B and how they use 340B savings to support patient care. And then I'll be turning things back to Courtney to talk about 340B advocacy and its role in the broader healthcare safety net and addressing issues with equity in care. In terms of the brief overview of the 340B program that we wanted to start off with, obviously in the context of healthcare programs, 340B is often overlooked as compared to, say, Medicare or Medicaid. Everyone knows Medicare and Medicaid. 340B is not as often discussed, even in many health policy circles, but it has been around for some time. It's a program that has had strong bipartisan support that Congress first enacted in 1992. And over the years, it's grown in size because of Congress's recognition of the role it plays in helping fund the healthcare safety net. There are a number of different types of healthcare providers that can participate in the program, each a different type of safety net provider. And we'll talk in a few moments about those, what types of providers can participate in 340B. But I'll note that after first enacting the program in 1992, Congress added children's hospitals in 2005. And then in 2010, Congress, as part of the Affordable Care Act, did expand the program to include certain types of rural hospitals and cancer hospitals. And really at its core, what the 340B program does for the safety net is it helps provide financial resources to safety net providers that they can use to finance patient care. These financial resources are funded by discounts made available from drug manufacturers. As a condition of participating in either the Medicare or Medicaid programs, drug manufacturers must offer outpatient drugs at a discounted price to those safety net providers that participate in the program. And because those providers were able to buy drugs at a discounted price, they are able to generate savings. And these financial resources are able to fund a number of different types of services to support care for patients. And we'll talk in a few minutes about what those services are. In terms of when we talk about the 340B program, we often talk about the purpose of the program. What did Congress intend when they created the program? And as you'll see here, we do quote some language that comes straight from Congress. When Congress was debating the creation of the program in the early 90s, they talked about what they intended for this program to accomplish. And they said that they wanted to allow the safety net providers that participate in 340B, as what we call covered entities, to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. And so when we said that really the goal of 340B is to finance patient care, it's to provide resources to providers that they can use to finance patient care. That's where it comes from. It comes from this language about stretching the scarce resources that are available to safety net providers so they can provide patient care services. And I want to talk about those covered entities, those different types of providers that can qualify for the 340B program. And we often put them into two different categories. There's the hospital category, and then there's the federal grantee category. And I'll talk about the grantees first. These are all different types of healthcare providers, and the commonality across all of them is that they receive some sort of federal grant funding from the federal government. Federally qualified health centers receive grants through HRSA, the Health Resources and Services Administration. So too do Ryan White HIV/AIDS clinics. They receive Ryan White HIV/AIDS program grants from HRSA. We also have a number of types of health centers, TB, Black Lung, family planning centers that receive Title X grants. All of these different types of entities receive grant funding. And because they've received that grant funding, they are able to qualify for the program. In the hospital category, the eligibility is a bit different. They're not qualifying because of the receipt of federal grant dollars, but they are qualifying because of their high volume of care to either low-income or rural patients. And the commonality across all of the hospitals is that they must be publicly owned or operated, or formally granted governmental powers, or they can be a nonprofit hospital if they have a contract with state or local government to provide healthcare services to low-income patients. But with the exception of the critical access hospitals, all of the other types of hospitals must serve a high volume of care to low-income patients. They have to have a minimum Medicare DSH, or disproportionate share adjustment percentage. That means they disproportionately treat a high volume of Medicaid and low-income Medicare patients. In critical access hospitals, they don't have a minimum DSH adjustment percentage requirement, but they qualify because of their care for rural patients. They have 25 beds or less, and they are located in remote parts of the country and are part of the safety net for rural populations. When we talk about covered entities, we really talk about them as being safety net providers, and they really form a crucial part of the healthcare safety net in this country. And sort of globally, the hospitals, the grantees combined, these 340B covered entities, have historically been a really key part of maintaining the safety net. And when we talk about that, we really focus on the long history that the program has had, with bipartisan support from members of Congress of both parties. And again, focusing on that language straight from Congress about the purpose of the program, using these 340B savings to stretch their resources, reach patients, and provide comprehensive services. Now, focusing a little bit more on the hospitals in particular, I wanted to just highlight a few quick data points that really show not just any hospital can qualify for 340B, but only those hospitals that serve high volumes of care to low-income patients. And so specifically when we focus on those Medicare DSH hospitals, we see that 340B hospitals treat a lot more low-income patients. They're treating a lot more Medicaid patients. They're providing a lot more care to Medicaid patients. Even though they make up only 43% of hospitals, they're providing 75% of Medicaid inpatient care. And not surprisingly, in terms of their financial health, they operate on low margins, with the average 340B DSH hospital operating in the negative. In terms of how 340B hospitals use their savings to support patient care, there are a variety of ways that they use their savings and how they report and talk about the value of 340B. I think a few commonalities that we see across all hospital types. They report using 340B to support their uncompensated care, and they provide very high volumes of uncompensated care. They also use 340B to offset their low reimbursement from Medicaid. Medicaid historically underpays providers, and they have shortfalls, but they can use 340B to plug those gaps. One way that hospitals use 340B is to provide free or discounted drugs to low-income patients. But they also use 340B to provide and fund a broad variety of clinical services, even outside the pharmacy. And with respect to rural hospitals, they're unique in particular, the financial struggles that they face. And they report that in some cases, 340B really helps keep the doors open. Without 340B, they may not be able to stay in operation. So these hospitals that, again, are really a crucial part of the safety net, we talk about 340B and Medicaid side by side because Medicaid is the backbone of the healthcare safety net. When we think of federal healthcare programs that are part of the safety net, Medicaid is really what we think of. But there really is this intrinsic link between 340B and Medicaid, because 340B hospitals have to treat a high volume of Medicaid patients to qualify for the program, because 340B hospitals provide so much of the Medicaid services in this country. And so when Congress chose to expand health coverage in this country by expanding Medicaid, it really also increased the importance of the 340B program. And so when we advocate for the safety net, we really encourage advocates to talk about protecting Medicaid means protecting 340B because they are so linked. And also, as part of our 340B advocacy, we also really focus on how we describe the purpose of the program. Because certainly the high cost of drugs is a very high profile issue right now that is consuming a lot of time for consumers and advocates and members of Congress and policymakers. And 340B is a part of how we can help support providing access to low-income drugs. One way that 340B hospitals use the program benefit is to finance drug discounts for low-income patients. But it is not the only way that 340B hospitals use the program benefit. And the program itself, it does not have a sole purpose of providing access to discounted drugs. 340B is also about funding broader clinical services outside the pharmacy. And so 340B is not a patient assistance program. It finances a variety of services, but certainly access to discounted drugs is one of the types of services that hospitals are able to fund because of their 340B participation. And the last comment or aspect of the 340B program I wanted to highlight is to talk about the role of community pharmacies in the 340B program. And this has been an area where there's been a lot of attention in the news and amongst policymakers and in the courts. One of the ways that 340B providers are able to access savings from the program is by partnering with community pharmacies. Hospitals and other providers can enter into contracts with pharmacies in the community where they can have their partner pharmacies dispense 340B drugs on the hospital's behalf to the hospital's patients. And this helps stretch those 340B savings and generate more financial resources for the hospital that they use to finance patient care. Unfortunately, we've seen several drug manufacturers in the last year or so that have begun to deny 340B discounted pricing for drugs dispensed through these community pharmacies. Fortunately, the agency at HHS that administers the 340B program, HRSA, has notified these manufacturers that their denials of 340B pricing violate the law. But these manufacturers are continuing to deny 340B pricing. And so HRSA hospitals and other providers are continuing to urge HRSA to penalize manufacturers that deny 340B pricing and take action to protect the safety net. And you'll see that we highlight here the value of 340B savings to hospitals. On the next slide, we really talk about how the increased savings from 340B community pharmacies finance care for low-income and rural patients. And so the ask for HHS in terms of how 340B advocates are talking about the program is to protect 340B so that we can protect patient care and stop these cuts to the 340B program. And this is just a perfect example of one of the key issues that advocates can become involved with in support of the 340B program and in support of the safety net. So with that, I'm going to turn things over to Courtney to talk a little bit more about advocacy and the role of Medicaid and health equity.
Thank you so much, Jeff, for that fantastic overview. As Jeff stated, the 340B program always matters to patient care, and particularly in three core areas. In terms of safety net hospitals, the hospitals are truly on the front lines of treating underserved communities and patients who may be suffering from chronic and life-threatening diseases and conditions. The bottom line is that any cuts to the 340B program could actually result in diminished services provided to chronic disease patients. Access to care is also paramount, and 340B hospitals actually help to serve, as Jeff reviewed, low-income and rural patients, both during the pandemic and beyond. And this probably is more important to us today than ever before. The savings from drugs that are purchased at discounted prices are used directly for patient care. Any changes to the 340B program could eliminate access to very important needed treatment and services. And then rural communities, as was mentioned, geography does matter. And so the institutions must show that they treat, again, large numbers of low-income patients or those who are living and residing in rural communities to qualify for the program. So any restrictions could result in rural hospitals closing, eliminating access, and restricting those who actually depend on rural hospital providers for treatment and very much needed services. 340B meets the needs of the community. So we've talked about access to care, but specifically, hospitals are often embedded into the fabric of the communities that they're serving, making accessible care critical. So making sure that care is easy and readily available to all patients is of paramount importance. 340B actually works towards eliminating access challenges by offering service lines, such as for diabetes care, cardiovascular disease, and even access to such things as bilingual and bicultural translation services and providers. Addressing transportation constraints is another critical area. 340B savings actually allows hospitals to provide services such as transportation, outpatient disease education programming, nutrition counseling on healthy foods, and supporting the ambulatory care patient network. Delivering emergency care and support is also something where safety net hospitals are using their program savings to address the diverse needs by offering care tailored to specific patient populations, including those with advanced disease, such as liver disease and renal. So in mentioning some of the chronic disease areas, the concerns in the era of COVID-19 and beyond really focus on access, cost, equity, and navigation. Access to medicine, treatment, and life-saving therapies, the cost of care, the burden on patients of care with COVID-19 and comorbidities is real. Equity in getting to providers without restrictions and amplifying telehealth and other viable interventions around access, and navigation, the system and understanding of where to go to actually help receive the care that's needed. In terms of navigating access to care and support, I wanted to provide a little more detail on the importance of the environment of care. As you can see in the graphic, healthcare facilities, schools, childcare, community programs, transportation, our work environments, access to food, housing, and parks, open spaces, and playgrounds are all important factors that actually contribute to patient support, to patient navigation, and to medication access. There is both an interdependence as well as an intersectional link between all of these contributing factors that enable and empower health and well-being. In addressing the social determinants of health and 340B advocacy, one of the main considerations in the array of factors that we just reviewed in patient navigation is taking a look at moving healthcare upstream. And those factors are needed to address the persistent and costly healthcare inequities that continue to burden the healthcare system. These are impacts that really impact the entire patient network and communities from a population health lens. Typically, solutions to care are focused around the downstream effects, charity care and Medicaid, as Jeff reviewed. However, there are other factors that we just illustrated such as programs around transportation and food that have an individual level impact. But more broadly, where we are right now as we continue to understand the broader impacts of our advocacy are the need for more systemic change and advocacy amplification for the safety net from the lens of social change and justice. So the adoption of upstream strategies provides more large-scale population health improvements, and this work actually must occur in parallel with broader community-wide efforts. So we're implementing the solutions to care to improve health more broadly through the 340B program. So with that, protecting 340B and safety net hospitals from a policy and advocacy lens is really framed around 4 really important areas. The ask is really to make a wise choice, and this mnemonic is to write an op-ed expressing support for America's safety net community and specifically support for 340B hospitals. As was just highlighted in the first section, the community pharmacy issue continues to be something that burdens and potentially restricts large-scale access to care. And we want to make sure that no patient is denied access to treatment and services that are needed. Issue a statement or newsletter post on the importance of protecting 340B hospitals and safety net providers in the era of COVID-19. With the Delta variant raging in our communities, this is probably more important now than ever before. Join a sign-on letter or send a letter to the Hill expressing support for 340B hospitals that are on the front line of chronic disease patient care. And educating membership, including sharing materials, social media, and taking a positive or neutral position to protect 340B. So when we're talking about the hashtag #ProtectThreeFortyB, let's be specific and intentional on what that means. Protecting 340B means partnering with local 340B hospitals. It means focusing advocacy on equity for all patients, regardless of socioeconomic status or condition, and also regardless of geography. It also means opposing efforts in Congress and states that are attempting to limit or restrict the scope of the 340B program. Protecting 340B, the goal is really to minimize negative response to the 340B program and engage in dialogue that produces balance to stakeholder outreach and encourage ongoing support for protection of the program. Thank you. I'm Courtney Lang with Langholm Partners. My colleague Jeff Davis and I encourage you to access additional resources at 340B Health. Specifically, 340B at a Glance will provide you with a tremendous overview of the information that was presented on today's webinar. Many thanks to Elizabeth Johnson and the colleagues at NMAPA for this opportunity to share about 340B.
Thank you again to our wonderful speakers, Jeff Davis and Courtney Lang. We appreciate the time it took to put this presentation together and to record with us. We look forward to working together with you in the future.